A 72-year-old female was referred to us for the favor of EUSSOS-CRC for suspected lower CBD block and cholangitis. Ultrasound was just showing dilated bile duct in a gallstone disease. So we did EUS. You can see once we position ourselves in the D2, we gently withdraw, and you can see the entire length of the bile duct in the cross section here, which is dilated. Gallbladder has few stones, and now we'll try and push the scope a little bit and try and get into the ampullary area. And this is how you see ampulla of water. Very, very gently we are maneuvering, and we're trying to see the block here. So there is a small stone there which is impacted. We'll try and get the proper positioning of it. You can see the dilated CBD with a small layer of sludge, which actually could be purulent material. So whenever you see some echogenic filling defect in the bile duct, it's usually purulent material, especially in impacted stones. You can see here in the prepapillary portion of the pancreatic duct also. So there is some reflux of the pus in the pancreatic duct. You can see that. So that's why patient has biliary pancreatitis, and you can see very well both the ducts now with the impacted stone causing posterior acoustic shadowing. So sometimes ampulla is extremely challenging when there is edema. You can see the pancreatic duct and the bile duct both having filling defects inside in the form of echogenic material, could be purulent infected bile. So it's very important to evaluate the ampulla again and again. Push your scope. You can see a posterior acoustic shadowing impacted stone there. Yes, that's the stone you can see here at 8 o'clock position. It's an impacted stone right at the ampulla, and this you need to confirm this again and again, because on the basis of EUS you will decide the next line of management. You can see some free fluid peripancreatic because of pancreatitis. You can see here at 5 o'clock position a small pocket of fluid there. So in absolutely no doubt this patient needs an intervention. We know that there is no obstructing mass lesion in that area, but you can see the reflux. This is how pancreatitis sets in, perhaps, when there is obstruction of the lower end of the ampulla. Then the purulent bile can reflux into the pancreatic duct and can cause, you can see that impacted stone there now. Now you can see the impacted stone. Yes, this is the impacted stone, very well demonstrated at 6-7 o'clock position. One has to really master over a period of time. You'll be able to see this difficult areas with some practice. Very gently we are coming out. We saw the pancreas. There is some edematous pancreas in the body, no doubt about it. Some lobulation as well, and no obvious mass lesions. So immediately we went with duodenoscopy, and you can see the stone which was impacted right at the ampulla is seen very well. We will prefer, rather than going selective cannulation, I prefer to use a needle knife and do needle knife pre-cut over the stone and deliver the stone like episiotomy. So something like that we have to do. We engage the needle at the level of the ampullary orifice, and you can see some pus coming out. So now we're going to make a zipper incision, because a very big bulging ampulla, we know intraduodenal portion of the bile duct is bulging, so we can make a zipper cut up to the upper end. You can see that the stone is there and the pus is coming out, and now the stone just pops out and sudden gush of infected bile with pus is seen from the ampulla. So it's important to make a big cut and go right up to the most bulging part of the ampulla, so that you do not struggle thereafter to cannulate the bile duct again. That's the stone which we extracted. So we make sure that the entire duct is clear. We know that there are no other stones. So effectively, if you can just leave this patient here, it's fine, but it's important to do a formal sphincterotomy, whatever remaining part of the biliary sphincter, if required. So we are cannulating along with sphincterotome here, you can see here, and it's a standard practice. We always place a guide wire first deep into the biliary system and then inject contrast. Sometimes when there is severe purulent cholangitis and if cholangiogram is not needed, we may avoid injecting contrast. So this is our practice in selective cases. We have placed the wire deep into the system, and as I had mentioned that we already have a very good EUS cholangiogram. Our wire is deep into the biliary system. We'll now extend the biliary sphincterotomy a little bit, as you can see here. This is the formal biliary sphincterotomy after a proper needle knife. So this extension is important. You can see a sudden gush of infected purulent bile and frank pus. So once this is achieved, try and avoid injecting contrast whenever you have severe purulent cholangitis, because we all know that when you inject there has to be some positive pressure in the ductal system. So it will further lead to severe infection and cholangiohepatitis. So now after biliary sphincterotomy, we will sweep the duct with a balloon. It's our practice to use balloon as far as possible in stone disease in the bile duct, always, except there are very small stones and it can be removed easily with the dormia. It's always practice to use a balloon catheter. We go right up to the common hepatic duct, inflate the balloon, and then gently stroll the bile duct completely clean. Now, since we know that there is gallbladder in C2 with stones and severe purulent cholangitis, sometimes some pus flakes, they do escape in the intrahepatic biliary system, and they can come down and do some partial occlusion again. You can see how edematous the ampulla is because of impacted stone and pancreatitis. So we prefer to leave a small stent till the gallbladder comes out, especially when patient has undergone severe symptoms due to purulent cholangitis and pancreatitis. So it's our practice to leave a 7 French stent. We know that there is some amount of pus which has flown out. Routinely in malignant obstructions, we always prefer a 10 French stent, and in benign obstructions such as this, when the duct is cleared, the stone is out, we can just leave a stent to act as a wick, where whatever comes down may drain by the side of it. So we are leaving a 7 French stent here over a guide wire, and this marks the end of the procedure. So again, role of EUS as well as ERC in biliary pancreatitis cannot be undermined. It's our practice that every patient with suspected biliary pancreatitis without definite evidence of stone should undergo an EUS followed by ERC if required, only if you feel that ductal decompression is required.